Hi, I am presenting my week 4 soap note on an adult patient with a pulmonary complaint. So, I am presenting my patient AO. I saw him on 4/28/26 in the clinic with my preceptor. We did a joint visit. He is a 47-year-old white non-Hispanic male who presented to the clinic unaccompanied with the chief complaint of I have been coughing for about a week and now I feel short of breath. It's important to note that this patient was a good historian. He answered questions appropriately. He came into the clinic saying he'd been experiencing a cough for 1 week and he developed some accompanying shortness of breath for the last 4 days. He described the cough as dry and persistent. There was no sputum. And the coughing episodes were worse at night that were causing a disruption in his sleep. He described the cough as feeling deep in his lungs. He said that he's been using Delsum cough syrup twice daily for the past few days. He couldn't remember if it was the last 2 or 3 days. And then the Ricola cough drops throughout the day. He doesn't feel like they're working though. He also is using his albuterol inhaler every 4 to 8 hours for shortness of breath as he feels like he needs it. He says it does help, but then it wears off and the shortness of breath returns. He says he feels like his chest is constricted and that he can't get enough air into his lungs, and he reports a subjective fever. However, he hasn't taken his temperature. He has a mild sore throat, runny nose, and fatigue, denies any chest pain, irregular heartbeats, abdominal pain, difficulty urinating. So his medical history is significant for asthma, hypertension, depression, and obesity. Asthma, hypertension, and depression are all well controlled on medication. Asthma, he was diagnosed in childhood and he's been taking his ICS/LABA, which is a Symbicort. He's been taking losartan for his hypertension and then fluoxetine for his depression. On physical exam, he's a well-appearing, overweight adult male, appropriately dressed and groomed, speaking in full sentences with no shortness of breath noted, and appeared to be in no apparent or acute distress. He did have some redness in his posterior pharynx. There was no exudate on his tonsils. He did have some mild cervical lymph node tenderness to palpation and some mild lymphadenopathy in those cervical lymph nodes with some scant clear rhinorrhea. His cardiovascular system was intact, S1 and S2 heard with no murmurs, rubs, or gallops. Radial and posterior tibial pulses +2 and cap refill at less than 3 seconds with no dependent or extremity edema. His respiratory system had a regular rate and depth of breathing, but his right lower lobe did sound constricted with air movement and diminished breath sounds, also noted to have fine crackles. His lower left lobe had a faint expiratory wheeze. The other lobes were clear to auscultation. His skin was warm, dry, pink, and intact, alert, oriented, and appropriate mood and affect. His vital signs were unremarkable, within normal limits except for his temperature, which was 100.1. His weight, height, and BMI are consistent with obesity at 221 pounds, 5'10", 31% BMI. So for this patient, my differential diagnosis are acute asthma exacerbation, community-acquired pneumonia, and then an acute upper respiratory infection. I ruled out the acute upper respiratory infection as most of his symptoms are a lower respiratory. And then the acute asthma exacerbation, I felt like was important to work up and consider because the GINA guidelines state that an acute asthma exacerbation is characterized by a progressive increase in symptoms like shortness of breath, cough, wheezing, and or chest tightness. And when assessing this patient, it's really evident that that diagnosis was one to consider because the patient was experiencing all of that, a dry persistent cough that was worse at night, wheezing, chest constriction, and then increased use of that albuterol inhaler that did provide some relief. He also did report that he's been recently ill with a viral illness. The other one to consider was that community-acquired pneumonia. This was a second differential diagnosis that I had. The GINA guidelines also stress the importance of assessing the pneumonia symptoms like crackles because that is a finding that is not consistent with an asthma exacerbation. So if you find crackles, it should be worked up separate. So I know we're supposed to have one diagnosis, but because of the patient's clinical presentation, I could not just have one diagnosis for him, as I did find that he was having both an asthma exacerbation and community acquired pneumonia, and it's possible that the asthma exacerbation was triggered by pneumonia. So the plan for this patient, according to the American Thoracic Society and the GINA guidelines, were to get a chest x-ray, a 2-view chest x-ray, check his pulse oximetry, make sure he's oxygenated, and then do a peak expiratory flow and gather labs. So that would be a CBC, CMP, and then COVID and influenza to rule that out. So his chest x-ray 2-view did show some suspicious infiltrates that required clinical correlation. And we were able to clinically correlate those through our assessment and vital signs. His pulse ox was 93 on room air. His peak expiratory flow was also diminished at 436, which is below his recommended or expected rate. So according to the GINA guidelines and the American Thoracic Society guidelines, to treat both an acute asthma exacerbation and community acquired pneumonia, continue the albuterol 2 puffs every 4 hours as needed. Add an oral prednisone 40 milligrams once daily for 5 days. And then to continue that budesonide formoterol 2 puffs BID plus a PRN dose of that. And then for the community acquired pneumonia, we treated him with the Augmentin or amoxicillin clavulanate 875, 125 twice daily, and then the azithromycin taper, the Augmentin for 5 days, and then the azithromycin taper. We treated him 500 milligrams on day 1 and then 250 milligrams on days 2 through 5. So educated the patient, you've got to take the entire course of antibiotics even if you're feeling better. The antibiotics could cause a GI upset, including nausea, vomiting, and diarrhea. Take it with food. And then to make sure he had good follow-up. So if symptoms were improving in 48 hours, he needed to return to the clinic, or sooner if they were getting worse. If the symptoms were worsening or he was developing increased shortness of breath, difficulty breathing, anything like that, we instructed him to go to the emergency room, and then otherwise we scheduled him back in the clinic in 1 week.